Bismillahirrahmanirrahim. Assalamu alaikum dear students. Welcome to your channel The Anatomy Canvas. In today's class of the development of heart, we are going to discuss with the septum formation, and the learning outcome for today's class are to understand the septum formation in the truncus arteriosus and conus cordis, septum formation in the ventricles, and to discuss about their clinical correlates. So first we will study the septum formation in the truncus arteriosus and the conus cordis. During 5th week of development, pairs of opposing ridges appear in the truncus. Here you can see this yellow color ridge is called the right conotruncal ridge or right truncus swelling that appears on the right superior wall. This is also called right superior truncus swelling. Another swelling appears on the left side, and this is called the left inferior swelling. So both of these swellings, the right superior swelling grows downwards and towards the left, and left inferior swelling grows downwards and towards the right. So both of these swellings have a spiral course, and while they descend, they meet in the midline and they fuses with each other and completed the septum. And because of their spiral nature, there is the spiral course for the outflow tract, and truncus and the common septum is the spirally arranged. So right superior truncus swelling grows distally and to the left. This yellow color is the right superior swelling, and the left inferior swelling grows distally and to the right. So this maroonish color swelling is left conotruncal swelling. It grows distally and towards the left. What happens next is that while growing towards aortic sac, swelling twists around each other. So you can see both of these swelling, they are twisting around each other, foreshadowing the spiral course of the future septum. After the complete fusion, the ridges form aorticopulmonary septum and divide the truncus into aortic and pulmonary channels. So I again repeat, this one is the right conotruncal swelling and this one is the left conotruncal swelling. So right conotruncal swelling grows distally and towards the left, and left conotruncal swelling grows distally and towards the right, and both of them having this spiral course, and when they fuses with each other, the arrangement of the conotruncal septum is the spiral arrangement. So the conotruncal ridges are swelling. Basically, they are derived from the neural crest cells, which are derived from forming the endocardial cushions in the truncus arteriosus and conus cordis, and they fuse at the conotruncal transition and zip proximally and distally to form the aorticopulmonary septum. So here in this diagram, you can see this is the 5th week of development. The right superior is growing downward, and left inferior is also going downward towards the right side. Here you can see the further growth of both of these swelling. Here you can see both of these swelling are almost fusing with each other, and in this diagram you can see the arrows shows the spiral arrangement of the outflow chambers from both the ventricles. So this is the yellow and green color shows the aorticopulmonary septum which is developing, and very important to know, which is also your MCQ, that the cells which are forming the aorticopulmonary septum, they are actually neural crest cells. So neural crest cells originate in the edges of the neural folds in the area of the hindbrain. Then they migrate through this area. This is the initial migration. Then pass in the circumpharyngeal range. Then they passes through the circumpharyngeal range. They migrate through pharyngeal arches 3rd, 4th and 6th, which is again your another MCQ. And this migration and their arrival and formation of the aorticopulmonary septum, all of these factors are regulated by the secondary heart field through the notch pathway. This is very important to understand, because if there is any anomaly in secondary heart field or any anomaly resulting in the deficiencies in notch pathway, or any anomaly in which the neural crest cells fails to migrate, so all of these factors will lead to the defects in the conotruncal septum formation and will lead to defects in the outflow region. So here again you can see these are the neural crest cells which are migrating from the edges of the neural tube in the area of the hindbrain through the pharyngeal arches 3rd, 4th fourth and sixth, and finally reaching in the region where they will form the aorticopulmonary septum. So outflow tract defects are typically due to failure of the neural crest cells derived conotruncal cushions. Associated with other disorders affecting neural crest cells like DiGeorge syndrome, fetal alcohol syndrome, that is the chromosome 22 mutations, etc., can also arise due to defects in secondary heart fields, hand to retinoids syndromes, etc. Examples include the persistent truncus arteriosis, transposition of great vessels, aortic and pulmonary stenosis, and tetralogy of Fallot. So please remember, these all outflow tract defects are either because of the failure of the neural crest cells to migrate and arrive in the region of the conotruncal cushions, or because of the effects in the secondary heart field. If there are defects in secondary heart field, then it will also leads to defects in the conotruncal septum. So we will discuss all of these anomalies later on in today's class. Now we are going to discuss the septum formation in the ventricle. So first you have to understand 2 points, that interventricular septum is basically consists of 2 parts. One is muscular part and other is membranous part. So first we will discuss the development of the muscular part. By the end of the 4th week, 2 primitive ventricles begins to expand. So in this diagram you can see the 2 primitive ventricles are expanding, and when they expand from the outside, continuous diverticulation and trabeculation formation occur on inside in such a way that their medial walls are opposed to each other, and then the medial walls gradually fuses with each other and they will form the muscular part of the interventricular septum. So please remember, these are the primitive right and left ventricle both, and they grow outside. Their growth is outside, and there is diverticulation and septation on the inside, and medial wall, this is the medial wall, and when medial wall fuses with each other, it will form the muscular part of the interventricular septum. So interventricular foramen, here you can see this is the interventricular foramen, and this is the muscular part of interventricular septum, which is formed because of the opposition of the medial walls of the 2 ventricles, and this area is the interventricular septum. Interventricular foramen. So interventricular foramen above muscular portion of interventricular septum shrinks on completion of the conus septum. So as I have told you that the conus truncus arteriosus is forming here, and conus cordis is going to divide the outflow chamber. This conus cordis, conotruncal septum, also contribute to complete the septum formation in the interventricular area. So here the completion of the conotruncal septum will contribute and will form the membranous part of the interventricular septum. So during further development, outgrowth of the tissue from the inferior endocardial cushion along the top of the muscular interventricular septum closes the foramen. Third source is this endocardial cushion inferior part, which will also contribute to the formation of interventricular septum. It's a membranous part. So this tissue fuses with abutting parts of the conus septum. Complete closure of interventricular foramen form membranous part of interventricular septum. So I again repeat, this is the muscular part of the interventricular septum. This part is formed by opposition of medial walls of right and left ventricles, and this area will be the membranous part of interventricular septum, and this will be formed partly by the conotruncal septum, which is forming over here, and partly by the inferior part of the endocardial cushion. So these all 3 sources will contribute to the formation of the interventricular septum. Again, a very nice diagram to show. Here you can see this is the common atrioventricular canal. This is the interatrial septum, which is also called septum primum, which forms a curtain-like area and divides the two cavities initially. And here you can see the muscular part of intraventricular septum, which has started to develop. So in this diagram, you can see the atrioventricular canal is divided into two separate areas, and here the AV cushion is present. The septum primum has grown downward, and here ostium primum is present, and also at the same time the muscular part of intraventricular septum is going to develop. In this diagram you can see the ostium primum is present, also the septum primum is septum spurium has also developed, and it will contribute to formation of the septum secundum. Here you can see the opening which is called ostium secundum, which is formed because of the apoptosis in the septum primum, and at the same time when this ostium secundum is formed, the ostium primum will be closed by opposition of the septum primum with the endocardial cushions. Here you can see the muscular part of the interventricular septum is also complete, but interventricular foramen is present, which will be later on completed by formation of the membranous part of the interventricular septum. So in this diagram you can see the membranous part of interventricular septum is completed. These are the atrioventricular canals, valves which are forming. Here you can see bundle of His is forming, and you can see also the ostium primum has completely closed. Ostium secundum is present, and this ostium secundum will form the foramen ovale. So this is a good diagram to show the development of atrial as well as the ventricular septum at the same time, also with the formation of the foramen ovale, the division of the two atrioventricular canals along with formation of the atrioventricular valves. So how the semilunar valves form the also outflow cushion dependent area. So you must remember this is the common conotruncal area, and these are the conotruncal septum which is forming and dividing the conotruncal area into two, the aorta and ventricle. When these are forming at the same time, the two swellings appear on each side of the conotruncal septum, and with the division of the formation of the conotruncal septum, these swelling also form in both the area, the right in the aorta as well as in the pulmonary artery. So you can see these two swellings which are present on both sides. Another third swelling also appear in both the aorta and pulmonary artery, and when these swelling fuses, they will contribute to formation of the semilunar valve. So in this diagram you can see these are the tubercles. Here you can see these are the tubercle, and in longitudinal section you can see the tubercles are present over here like this. When this tubercle hollows out and they thin out, they form the valves. So this is the way how the semilunar valves will be formed in aorta and the pulmonary artery. Formation of the AV valve also almost similar way, dependent on AV cushions and ventricular myocardium. So here you can see the atrioventricular valves are forming in these areas, which will form the developing mitral and the tricuspid valves. Now we move on to the clinical correlates. The most common clinical correlates in heart are the ventricular septal defects. They occur as an isolated condition in 12 per 10,000 live birth, and 80% of ventricular septal defects occur in muscular portion of the septa. This is again your MCQ. You must remember that 80% most common are actually VSTs, and out of VST 80% are in muscular portion. So MCQ can be either in that way or it can be in this way. These conditions, the ventricular septal defects, are the serious conditions and abnormalities associated with other abnormalities in partitioning of the conotruncal region. So we will discuss all of these one by one. First is the pulmonary stenosis because of the tetralogy of the fellow. So in tetralogy of the fellow, there is actually anterior deviation of the conotruncal septum. As a deviation of conotruncal septum anteriorly, you can see there is the stenosis of the pulmonary trunk, and because this pulmonary trunk is stenosed, there is higher pressure in the right ventricle, so there will be right ventricular hypertrophy along with interventricular septal defect in its membranous part. Also, the aorta will override and it will start from taking the blood from both the ventricles, and the another anomaly is the patent ductus arteriosus. So the different anomalies you must remember: pulmonary stenosis, number 1, number 2, overriding of the aorta, number 3, the septum defects in the interventricular septal defects in its membranous part, number 4 is the right ventricular hypertrophy, and also the number 5th, which is a patent ductus arteriosus. So the word tetralogy is actually misnomer, it should be pentology of the fellow. Actually it was written as tetralogy, so it is still known as tetralogy of the fellow, but actually there are 5 defects in this tetralogy, and these defects are pulmonary stenosis, basically pulmonary infundibulum stenosis, overriding of aorta, interventricular septal defects in their membranous part, right ventricular hypertrophy, and patent ductus arteriosus. The other signs of the tetralogy of fellow are the respiratory distress syndrome. There will be dyspnea with the rapid breathing. The characteristic is squatting position at rest to relieve the dyspnea. Cure and sabot, that is boot shaped heart in the x-ray. You can see this is the boot shaped heart which is present in x-ray, and also the cyanosis of the developing gradually with the intermittent severe spells and clubbing of the fingers and the toenails as well. So these are the other signs of the tetralogy of the fellow, which are general signs because of the dyspnea and decreased oxygenation. Next is the persistent truncus arteriosus and the transposition of the great vessels. So in persistent truncus arteriosus, the defect is basically that the conotruncal septum do not form and there is a common outflow chamber. So there is a persistent common truncus arteriosus taking blood both from the right as well as from the left ventricle, and also as the conotruncal septum contribute to formation of interventricular septum, its membranous part. So there is a defect in membranous part of the interventricular septum also. Patent common truncus arteriosus and mixing of the blood in both the aorta and the ventricle. Another anomaly is transposition of the great vessel. In this anomaly, we have studied in the previous slides that there is the spiral course of the conotruncal septum, and because of this spiral course, the aorta arises from left ventricular and pulmonaries from the right ventricle. But if conotruncal septum do not grow spirally and it descends as such downwards, then it will divide the conotruncal area into two equal, the aorta and the pulmonary, and in this case aorta will arise from the right ventricle and pulmonary arise from the left ventricle. Such a condition will always be associated with the patent ductus arteriosus. So next is the Dye-George syndrome. In Dye-George syndrome, there is a defect in chromosome 22q11 locus. This is the chromosome which is Q arm, that is long arm of the chromosome number 22, and there is a deletion. And there in Dye-George syndrome, basically there is a triad. First is congenital heart defects, second is immune deficiency, that is secondary to thymic hypoplasia, then the hypocalcemia due to small r, absent parathyroid gland. So baby have the this is the catch 22 with the chromosome number, and catch is the cardiac malformation, abnormal facies, thymic hypoplasia, cleft lip and palate hypocalcemia, and 22q11 microdeletions. So in Dye-George syndrome, the heart defects will be In this diagram you can see there will be the narrowing or the pulmonary stenosis as well as the ventricular septal defect, the right ventricular wall hypertrophy, and these are the defects which are present. The condition resemble more or less the tetralogy of the fellow. So this is the Dye-Jar syndrome because of deletion in chromosome 2211. Next is the mitral stenosis and the hypoplastic left ventricular. In this condition you can see there is the stenosis of the mitral valve, failure of the left AV valve, the tricuspid valve to form, and left ventricle and aorta become hypoplastic because of the reduced flow. So in this diagram you can see this is a stenosed mitral valve and hypoplastic right atria as well as the right ventricle, and hypoplastic left atria and left ventricle, and there is the hypertrophy on the right side. The condition will be okay in embryo as the oxygenated blood is coming from the inferior vena cava and can be distributed systemically via the ductus arteriosus. But this arrangement do not work so well in breathing infants since oxygenation occur in the lungs and there is the stenosis, while blood returning from the lung will not be distributed through the aorta into the other parts. So condition will be severe after the birth. So this is a summary of the clinical correlates. We have studied ventricular septal defects. We have studied the tetralogy of Fallot, which is actually a pentology. Also studied the right ventricular outflow region in which we have pulmonary infundibular stenosis, large defect in interventricular septum, overriding of aorta, hypertrophy of right ventricular valve. Another condition is ectopia cordis. You must remember ectopia cordis is a defect in the closure of the anterior wall of the embryo. So anterior wall of the embryo in the cardiac area do not close and heart is exposed to the exterior. Then we have studied the patent persistent truncus arteriosis, also the transposition of greater vessels and the valvular stenosis. So here I complete my today's class. The reference is the Langman's Medical Embryology. Thank you very much dear students for your attention. Again, I must say, if you have any question, so you can ask while chatting with me through your YouTube channel. And thank you very much for your attention. Till the next class. Allah Hafiz.